Let me first say that this was a absolutely enjoyable experience listening to the previous presentation, which is an exceptional coverage of the entire spectrum of neuroendocrine tumors, and highlighting all the important things, both in terms of the clinical symptomatology, the management, and the diagnostic approach. What I'm going to do is a much more restricted presentation, trying to highlight some of the features which we see in our own setting. Also, maybe raising issues which I'd love to hear an audience feedback about, specifically in terms of when we are confronted with patients in the context of limited resources, whether it's terms of human resource expertise or diagnostic capability, what are the improvisations that we can do to try and manage our patients despite those problems. But before I start with the presentation, I'd like to put on record my acknowledgements for the assistance which two individuals have provided me extensively while developing this presentation. One, of course, is our moderator, Dr. Alpesh Goel, and the other one is Dr. Velmurugan, who is currently an endocrine fellow with us in the department. And it's a lot of thanks to them for having assisted me in putting together this presentation. So the outline of my talk would be a little bit about epidemiology of neuroendocrine tumors, one slide on the world scenario, and then largely some information on how the Indian scenario compares and contrasts with that. And then I will essentially talk to you about two disease conditions, insulinoma and ectopic Cushing syndrome, because that's where some of the data available for us is, as Professor Kolsos mentioned, things like VIPoma, gastronoma, glucagonoma, VIPoma are really few and far between, and we really don't have specifically a large volume of experience from any center coming up from India. So this is the surveillance epidemiology and end results database, which comes from the National Cancer Institute in the US. And essentially what it shows is that over a period of time, this is nearly a 50-year journey, 40-year journey in this instance of the epidemiology of neuroendocrine tumors, that there's a dramatic increase in lung lesions, but there's also an increase in gastric carcinoids and also rectal carcinoids. And the other thing which is important is that there is this particular thing, and if you can see, while the absolute number of pancreatic neuroendocrine tumors perhaps still doesn't match the bronchial carcinoid story coming up in the lung, but there has been a clear increase which is visible in the last 10 to 15 years. And that possibly relates well with the appearance of certain diagnostic modalities, such as the endoscopic ultrasound and the somatostatin receptor associated imaging modalities. I'm going to stop here with regards to the information on the global data, and now shift. The next few slides will be on something called the Asia Pacific Neuroendocrine Tumor Registry. It says Asia Pacific, but it's largely contributed by 6 centers from India. And again, you'll see this is data from 3 cohorts. They had a cohort 1, which was established in 2001 through 2005, a cohort 2 of the next 5 years, and then the third cohort. And you can see progressively, with more interest and more diagnostic capabilities, the number of people has increased from less than 50 in the first cohort to nearly 150 in the next, and nearly 250 in the third cohort. Again, here you'll see that there is a striking jump in pancreatic disease. And again, this is really coming up around 2006 onwards, maybe again coinciding with the availability of certain new diagnostic abilities. The small bowel carcinoids are also coming up at the same time. And of course, this again mirrors and a slight increase in colorectal disease, which mirrors to a large extent what has been reported in the SEER database. Now, we can look at these in 2 respects. One, whether they are functional or non-functional, and whether they are symptomatic or they're non-symptomatic. Interestingly, the proportion of functional tumors seems to have declined over a period of time, whereas the number of symptomatic tumors also seems to have, as asymptomatic tumors has also declined. And that also means that a lot of stuff is coming up with relatively minor symptoms, with better imaging, better diagnostic capabilities, and our ability to pick up tumors. It possibly doesn't really reflect an increase in absolute numbers. It possibly does reflect increase in our ability to identify these particular lesions. In those with functioning tumors, and this was extensively covered by the previous speaker, flushing and diarrhea make about 70%. So these are obviously carcinoid syndromes. And amongst non-functioning tumors, abdominal pain was common. I forgot to mention one thing, that the 6 centers which have contributed to this Asia-Pacific net are all oncology centers. And you'll find that one of the important biases which come out in terms of reporting proportion of patients is what is contributing to the patient numbers. Is it primarily oncology centers? Is it primarily gastrointestinal or surgical gastrointestinal centers? But if it's endocrine centers, obviously it predominantly comes up as the functioning tumors, of which insulinomas becomes the most important part. This is again a sense of the contribution of the different diagnostic modalities, and you'll see that the ability to diagnose was dependent on conventional radiology, but over a period of time, endoscopic ultrasound and the various DOTA, DOTA-NOX, DOTA-TATES, DOTA-TETs have increased so that they have contributed increasingly to the imaging of these gastropancreatic neuroendocrine tumors. And the last point I like to make when I'm talking of this generic information is, and this is something which is important, we as endocrinologists possibly haven't paid as much attention to, is the grading in terms of the malignancy status, right? These are all actually tumors, and they are, depending on the Ki-67 and mitotic index, they are graded as G1, G2, and G3. And you can see that a predominant number of them are actually G1 and G2 in nature. However, if you look at lesions which are coming from multiple endocrine neoplasia, the likelihood of them being more aggressive and more likely to be G3 increases in those sort of series. So I'm going to stop on the epidemiology front and shift to the first of my two diseases which I'm referring to. One is insulinoma. Again, for us as endocrinologists, is really the most common functional pancreatic neuroendocrine tumor. Well, 99% or more are present in the pancreas. I will, of course, share with you a case vignette from our own department in a moment, which showed a non-pancreatic lesion. A small percentage are malignant, and about 1 out of every 20 or 1 out of every 25 are associated with multiple endocrine neoplasia type 1. And this is the case I was referring to. This was a patient who presented with a classical hyperinsulinic hypoglycemia, and during the diagnostic workup, there was a tumor which was found sitting in the right pituitary. As you can see, the DOTA-NOX scan clearly shows a very, very significant uptake. Patient was operated. This is the classical nests of cells histopathology. And on immunohistochemistry, this person had a positivity for chromogranin, for synaptophysin, and in this case, insulin. So chromogranin and synaptophysin are the classical immunohistochemical markers that we use. We're happy to report this particular patient had an absolute resolution of all her symptoms and is doing well ever since then. However, patients don't come to us with tumors. Patients come to endocrinologists usually for the evaluation of hypoglycemia, and very often for the evaluation of spontaneous hypoglycemia. And the left part of this flow, therefore, represents what we would normally do in a patient who's otherwise clinically well. We would very often actually subject this patient to a prolonged fast. If the person has hypoglycemia, during that critical sample, we measure insulin, C-peptide, ketones, and wherever possible, proinsulin, and also screen for sulfonylureas. If you look at Indian literature, you'll find that sulfonylurea screening has not been a very easily available modality for us, and therefore it gives us a problem. However, if you have high insulin, high C-peptide, and a sulfonylurea which is negative, it's a classical insulinoma or a non-insulinoma pancreatic hyperinsulinic syndrome or an insulin autoimmune syndrome. If the sulfonylurea is positive, it's obviously because of factitious hypoglycemia. If on a prolonged supervised fast there is no hypoglycemia, you may subject the individual to a mixed meal test, and they may be actually having an entity called reactive hypoglycemia. But again, that's one of those things to debate. I will not refer to the clinically unwell patient at all, though there are multiple other endocrine anomalies, including adrenal insufficiency, hypopituitarism, hypothalamic disease, and very, very rarely IGF-2 producing tumors, which may actually give an acromegaloid phenotype on looking at the patient, which may be also contributing to hypoglycemia. If, however, we get features which are consistent of a hyperinsulinic hypoglycemia, we are then obliged to do a pancreatic imaging, because the surgeon needs to be able to identify the tumor before they go in and operate. And that has been often an area of significant difficulty. What is important to point out here is that this is something which requires a multidisciplinary approach, and therefore, tumors such as this or lesions such as this are ideally managed in institutions where you have good, in addition to the endocrinologist, a good radiodiagnostic facility, nuclear medicine, a surgical thing, medical and surgical oncology, and if need be, a radiotherapy and palliative medicine. And that's very, very important. And thereby, there's a limitation sometimes in the non-metropolitan cities of India where tumors of this may find difficulty in management. Let me share with you some of the features of insulinoma. These are data from our own institute. They are a combination of two series. The first one, 1990 to 2005, about 31 patients, another 35 patients in the middle part of the first decade of this century, going on for about 10 years. Really not a huge amount of difference, but the points are the average age is about 35 to 40 years. There's no difference in the male and female ratio. It takes about 3.5 to 4 years in our setting to actually diagnose these people. A little shorter in the recent series, as you can see, about 3.5 years, a little longer in the earlier series. Preprandial hypoglycemia is consistent, but there are people who also present with postprandial hypoglycemia. So that's not, therefore, a very good discriminant in terms of whether it's one sort of cause or the other. Interestingly, more and more people presented in this series with symptoms, right? Hunger, palpitation, sweating, tremors, loss of consciousness, much more symptomatic disease, and therefore possibly contributing to an earlier diagnosis compared to the initial series. What about biochemical features? And this is trying to put in perspective our series with this one from the University of Verona in Italy, because it had, we could cull out similar features. Spontaneous hypoglycemia to the extent which really precluded the need for subjecting the patient to a prolonged fast was seen in nearly 2 out of every 3 of our patients. So this is possibly because our patients are presenting later in the course of disease, and just hospitalizing them and watching them as an inpatient is enough to see a spontaneous disease, a spontaneous hypoglycemia. Prolonged fast was actually needed in about 40% of our patients, whereas in the study from Italy, everybody had to undergo a fast. The other thing which is important for us to point out is that a vast proportion of people will actually have a hypoglycemia within the first 24 hours, and invariably everybody will have a hypoglycemia in the first 48 hours. And this is, if you're actually entered into the third day and you're still not getting a hypoglycemia, the odds of it to be an insulinoma become less and less. The severity of the disease was clearly more in our patients, again, possibly representing later a mean plasma glucose of about 30 as opposed to 40 in the Italian study, higher insulins, higher C-peptides, higher insulin glucose ratios. So again, suggesting that we need a better index of suspicion in our country because patients are going on for much longer before they're actually presenting with the disease. Couple of other series from India. This is from St. John's Medical College, Bangalore. Retrospective data over a 10-year period, about 16 patients. The point which I'd like to point out here is that they also had 3 patients of insulin autoimmune syndrome. And the only thing which is of relevance here was patients of the insulin autoimmune syndrome were older, number one. They had much more fluctuation in their sugars, so much more swings of hypo and hyperglycemia. They had higher insulin levels, clearly significantly higher insulin and C-peptide, and therefore also significantly higher insulin to C-peptide molar ratio. So once you're having insulin values of 100 and thereabouts, you're very clearly looking at an insulin autoimmune syndrome and much less likely to be looking at an insulinoma. This is information of a slightly different sort. This comes from KEM Mumbai, in which they looked at their patients with multiple endocrine neoplasia. This is a single center experience of 14 families with 18 cases. Just to point out that 5 out of 18 cases were insulinomas. And the second thing I'd like to point out was clearly more likelihood of multifocal disease. As you can see, multifocal, 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 and multifocal. And the second thing is more likely of more aggressive disease because hepatic and lymph nodal metastases were seen in 2 out of 5 of these patients. Small numbers, but still give us a window of looking into what we are likely to expect. And therefore, in insulinomas, if we're expecting multifocal disease, trying to scoop out a enucleate or solitary lesion may be fraught with danger. Now, this has been a very important part of the journey of most departments of endocrinology at PLOS with their colleagues in radiology and nuclear medicine and the localization. These are data from a very relatively earlier data, which span from the late 1990s to 2008 from the Christian Medical College in Vellore. Again, an important point to raise was that they used in this study approximately an average of 2 imaging techniques per patient, a helical or a spiral CT scan, very specific MRI, not as specific, DSA, not as specific, but basically none of them really gave exceptional good quality, sensitivity, and specificity, except for DSA, but that's not really been very well supported in studies elsewhere. These are again studies from KEM Mumbai showing that the localization for of these patients, again, CT had a reasonably good specificity, but did not give us very good sensitivity. The sensitivity of CT was about 68%, gave us a positive predictive value of about 90%, but missed a lot of lesions. So clearly there was need to go beyond CT and conventional MRI. And as you can see in the beginning, this is again data which came in the latter part of the 1990s and the early part of this century. Endoscopic ultrasound was just about coming into our diagnostic armamentarium. These are our own data and the studies which I talked to you about again, and I'd rather concentrate on the more recent part of this study. Very poor sensitivity with ultrasounds, very poor sensitivity with conventional CTs, much better sensitivity with multi-phase CTs, equally good sensitivity with MRI, but very, very good sensitivity with endoscopic ultrasound. 95% pickup compared to patients who were then confirmed on surgery. We also did intraarterial calcium stimulation in 4 patients in whom lesions were not identified by some of these imaging techniques, but it's very cumbersome, not easy to do, requires, it's a bit of a show you need to put on for it, and therefore it's not something that we do commonly. The other thing I'd like to point out is, for whatever reason, maybe it was our early days in the experience of using gallium dotinok, not a very good sensitivity with gallium dotinok. However, in a more recent publication from the Department of Nuclear Medicine, including colleagues from my own department, from pathology, and from radiodiagnosis and gastrointestinal surgery, this was a study which compared a head-to-head comparison of 68 gallium DOTA exendin 4 and a gallium dotinok PET CT with a stand, which is a gallium dotinok. There were 36 patients, of which 25 had histopathological confirmation. They included multifocal insulinomas and 1 sporadic and 1 MEN patient. And in the MEN, 1 patient had 3 lesions in one of these. So, it had a spectrum of disease. And the most important thing we found here was that exendin 4 actually performed brilliantly in this study. Now, whether time will continue to endorse these data, I don't know. But all 23 of the benign lesions were actually picked up by an exendin 4 PET CT. The dotinok PET CT, which I had said in the earlier series was as low as 25%, actually performed better out here, about 65% pickup of the benign lesions. The other thing which is important was that the dotinok PET CT showed up both insulinomas, and when there were concurrent non-insulinomas, neuroendocrine tumors, they were also picked up. But the exendin PET showed up uptake only in insulinomas that could help us, do a relatively conservative pancreatic surgery than to go in for a more extensive surgery. So one question which is often asked, and these are my own thoughts, and these are open to question, debate, and rectification, is when would you want to refer an insulinoma to a more experienced center? And there are not too many of these experienced centers because of the need for multidisciplinarity. I would say a suspected malignant insulinoma, multiple pancreatic neuroendocrine tumors, either sporadic or a part of an MEN1 syndrome, failed localization, and the first surgery not having been successful. And I think these are important things to understand, especially in centers where, despite there being a good endocrinologist, they may not have the support of a larger team of individuals, because we really benefit from the fact that we have very good gastrointestinal surgeons. We have regular radiology and nuclear medicine conferences where we discuss this. And then, of course, we have follow-up with exceptionally good pathology where they can do all the staining and then give us feedback on what has come out. So I think this is a big party when it comes to some of these complicated pancreatic neuroendocrine tumors. And the difficult ones, therefore, need to be referred to larger centers. I'm going to shift to the PRRT and just like you've highlighted, these are not PRRT only for insulinoma. These are data from PRRT from different centers for all neuroendocrine tumors to give a slightly Indian flavor to the very large series reported by Professor Kolstas. The 2 points I'd like to make, and this is number one, that as compared to individuals who received only 1 or 2 cycles of lutetium dotatate PRRT, those who received more than 2 cycles actually had a better survival outcome. So you need to persist with your lutetium dotatate. Don't do just 1 or 2 cycles and then give up. And the second thing, and which is a bit of a despondent news, but those who had more than 2 metastatic sites actually did not perform that well. And that's very important for us to understand and remember. This is another study, and this points out one more aspect, that sometimes we look at only imaging outcomes. But I think this study highlights the fact that you need to look at multi-dimensional outcomes when you're looking at a lutetium dotatate peptide receptor radionuclide therapy, not merely imaging, but imaging and clinical and biochemical, because a composite outcome sometimes gives you a slightly better picture than limiting it to only imaging. If you can see, if you look at only imaging, you'll find that complete remission was in a very, very small number of patients, whereas once you include clinical and biochemical, a number increases. So clearly we need to look at the patient overall and not just looking at what the tumor looks on imaging. If you're improving the patient in terms of clinical and biochemical outcomes, that itself is a positive as far as the individual is concerned. And a very, very recent study from our own Department of Nuclear Medicine here, looking at a combination of lutetium dotatate with capecitabine therapy. And I won't go into this in much more detail, except to say the overall survival was superior with lutetium dotatate and capecitabine. As you can see, whereas we'd crossed down to under 50% with just the lutetium dotatate, this was 75% survival. So we didn't even reach a 50% number here, which is good. Similarly, here also, the progression-free survival was also superior in case of those who got a combination of capecitabine with lutetium dotatate. Again, please remember, this is not a small study. This is about 150 plus patients, out of which about 50 were pancreatic neuroendocrine tumors. So again, good exploratory work done, and this may have value in future. The new thing which we've started doing, and I use that term advisedly because this work is done in the Department of Nuclear Medicine at AIIMS, is in those who are patients who are either stable or refractory to lutetium dotatate, is a new form of dotatate, which is an actinium dotatate, as opposed to a lutetium, which is a beta therapy. This is an alpha therapy. And alpha therapy is a higher energy therapy with a slightly lesser path length, and therefore it's supposed to be less damaging to the surrounding normal tissues, and it delivers more high energy to the tumor itself. And again, I'm not going to go into much more details to say these are very, very early data, 16 pancreatic neuroendocrine tumors, but initial results suggest that those who are refractory to lutetium dotatate and you're struggling to find other things to do, you can consider an actinium dotatate therapy. Shifting to the second and a smaller part of my presentation is ectopic Cushing's. Overall, as Professor Colsis showed, to be out 6, 8, 10% of all the patients, usually causes a rapid clinical course, especially when associated with malignant disease, unless it's because of the slow-growing bronchial carcinoid. And it's the most common cause is an underlying neuroendocrine tumor, and that's why this topic is being discussed today. The world data, and these are very recent values, again, 3 sets of tumors contribute maximally: bronchial carcinoid, small cell lung cancer, and gut neuroendocrine tumors, and out of which I think 2 out of these 3 are pertinent for today's conversation. You can see that that constitutes about 50 to 75 of all of these lesions are all ectopic Cushing's come from these 3 diseases. These are data from our own center. This is a total of 364 patients of Cushing syndrome, out of which 22 were diagnosed with ectopic Cushing's, 6%. Again, if you see, bronchial carcinoid, thymic carcinoid, and pancreatic neuroendocrine tumors constituted 15 out of these 22. About 2/3 of these lesions were contributed by these 3 specific lesions. And again, if you look at other similar size case series of 15 to 20 individuals from Christian Medical College Vellore, PGI Chandigarh, and KEM Mumbai, again, the bronchial carcinoid, thymic carcinoid, and pancreatic neuroendocrine tumors constitute the bulk of ectopic Cushing's in these Indian centers also. Again, a slight comparison of the clinical and biochemical features of ectopic Cushing's as opposed to the Pituitary or the Eutopic ACTH-dependent Cushing's. These are data from AIIMS. KEM and CMC. Not a huge lot of difference in most of the features in terms of evening cortisol, and LDST, but of course, as expected, hyperkalemia was more common in these patients with ectopic Cushing's. The important thing, however, was that you actually did get the occasional patient who suppressed their high dose, who suppressed their cortisol and high dose suppression, and that's important. The early series using inferior petrosal sinus sampling, the series from KEM Mumbai, was without using CRH, but clearly demonstrated a peripheral gradient. And that series also demonstrated the ability of dotatate to show a few patients. But still, I think the recognition of ectopic Cushing's using sequential scans, whether it's a CT of the abdomen, chest, abdomen, and pelvis and neck, the use of CRH IJV, the use of IPSS, the use of CRH or other stimulated IPSS is still relatively an early experience in India because of the limited number of centers which do this on a large scale. And again, that becomes a very important area for discussion as to how we should enhance our capacity in this instance. The management, of course, is being dealt with by Professor Kolsters in his talk, but by and large, the ideal situation is if you can localize the tumor and surgically remove it. Obviously, all the other things have been discussed, but using chemotherapy or somatostatin analogs, somatostatin receptor-based PRRT, medical therapy for hypercortisolism, and in the worst case scenario, to give some degree of relief, even a bilateral adrenalectomy. I'm going to stop my presentation here by giving a handful of concluding remarks. I think the incidence of neuroendocrine tumors has increased also because of more aggressive case finding and not necessarily because of an increase in absolute numbers. The critical part is multidisciplinary approach in managing neuroendocrine tumors. There seems to be a definite, some interesting data emerging on the Exendin PET for the localization of insulinoma, and I'm sure our surgical colleagues will welcome a preoperative localization. Somatostatin analogs has been very, very wonderfully demonstrated by the previous speaker, affect not only functional but anti-tumor effects, and clearly PRRT, at least to provide stable and progression-free survival, is an important method which should be made available to our patients. With these limited remarks on the Indian scenario, I'd like to stop my presentation. Thank you for listening.